Practical Pharmacokinetics, Part 4, Bayesian Application. Hi everybody, and welcome back to the PharmEasy Tutor. In today's video, we'll look at vancomycin's past, present, and future, and discuss new approaches to dosing it using pharmacodynamics. Now, for many years, we've been using pharmacokinetics and trough levels to dose vancomycin. We are now at a crossroads in pharmacy to advance to a new way of dosing vancomycin using the concepts of pharmacodynamics and AUC-MIC ratios. This represents a critical paradigm shift for many of us, but it is now the recommendation of consensus experts in the field of infectious disease and pharmacy to move in this direction. But are all of these recommendations sound ones? I'll present various options for the future. Do we keep on using trough levels, use Bayesian modeling and predictive software, or perform two-level kinetic analysis to dose vancomycin? Let's see in these next two installments of the PharmEasy Tutor. Vancomycin has been in clinical use since 1958. Despite using vancomycin for more than 60 years, there still are major gaps in our knowledge base regarding the most appropriate dosing approach. Even with multiple guideline revisions for vancomycin, the optimal dosing of and precise methods of monitoring its serum concentrations continue to elude clinicians. Numerous studies continue to be published in the literature regarding a variety of vancomycin dosing and serum level monitoring strategies, but we still haven't figured out how to dose it. Let's start off by talking about where we have been to get to this point. First, a bit of history. Question: where was vancomycin discovered? A. In the Gobi Desert, B. In the Borneo jungle, C. In the Brazilian rainforest, or D. In the Swiss Alps? Vancomycin was discovered in the Borneo jungle. Another historical question. Vancomycin was first found in A. Dirt, B. Water, C. Fish scales, or D. Algae? Vancomycin was first found in dirt. Let's go over a brief history of vancomycin. In 1956, Streptomyces orientalis was isolated from a soil sample obtained in the Borneo jungle. The organism produced a substance that displayed impressive antibacterial activity against most gram-positive organisms. The substance was given the name vancomycin for its ability to vanquish penicillin-resistant staph. In 1958, the FDA approved vancomycin. It was initially called Mississippi Mud because the first commercially manufactured drug was not well purified, only about 70% pure, and brown in color. The impurities in the product caused nephrotoxicity and infusion reactions. In 1960, the FDA approved methicillin, so semi-synthetic penicillins such as methicillin and oxacillin became first-line agents against Staph aureus, and vancomycin was relegated to a second-line agent. However, in 1980, MRSA emerged, and vancomycin became the first-line agent for the treatment of or empiric coverage of MRSA. Luckily, in 1985, a more refined product of vancomycin was manufactured, about 95% pure, which was associated with a decreased number of patients experiencing kidney injury, about 5%. Between the years of 2006 and 2012, vancomycin usage increased, and the standard of care was to monitor serum vancomycin trough concentrations to maintain them between 5 and 15 micrograms per ml. We've dosed vancomycin using trough levels for many years. Maybe there's a way that we can dose it differently. We know that formula-based dosing using population kinetic estimates are an imprecise method. Traditional antibiotic dosing regimens have been determined only by pharmacokinetic parameters. These pharmacokinetic formulas are plagued by being imprecise and varied and provide poor estimates of the AUC. We also know that in clinical practice there is considerable interpatient variability in vancomycin exposure, which leads to using formulas that will overestimate the vancomycin clearance by about 40 to 50%. So, is there a better way to dose vancomycin? Enter pharmacodynamics. Pharmacodynamic parameters can be used to design dosing regimens that optimize microorganism killing and counteract resistance. Pharmacokinetics deals with the disposition of the drug in the body, the absorption, distribution, metabolism, and elimination of the drug, whereas pharmacodynamics deals with the effect or action of the drug applied on the body. Here is a concentration time curve of a drug. You can see the familiar pharmacokinetic parameters of peak and trough levels, volume distribution, KEL, and AUC. These parameters are numbers and do not represent too much when it comes to drug action. With pharmacodynamics, we introduce relationships between the pharmacokinetic parameters and the MIC. The MIC is the minimal inhibitory concentration. So we get the peak to MIC ratio, the time above the MIC, and the 24-hour AUC-MIC ratio. You can see that these pharmacodynamic parameters better define the killing action of the antibiotic compared to the pharmacokinetic parameters. There are three pharmacodynamic properties of antibiotics that best describe their killing. These are, number one, concentration-dependent killing. The PK/PD parameter for this type of killing is peak concentration divided by the MIC. The goal of therapy is to maximize concentrations, because the rate of killing is determined by increased concentrations. The persistence effects are prolonged. The second type of killing is time-dependent killing. The PK/PD parameter for this type of killing is time of concentration above the MIC. The goal of therapy here is to maximize duration of exposure, and the rate of killing is determined by the length of time necessary to kill. Persistence effects are minimal. And the third type of killing is the type 3, time-dependent and persistence effects, where the PK/PD parameter is 24-hour AUC divided by the MIC. The goal of therapy here is to maximize the amount of drug. The rate of killing is determined by the persistence effects, which include the post-antibiotic effect. Persistent effects are moderate to prolonged. The antibiotics that exhibit concentration-dependent killing are aminoglycosides, daptomycin, and the fluoroquinolones. For aminoglycosides, it's best to have a peak to MIC ratio of at least 8 to 10 to prevent resistance. The antibiotics that exhibit time-dependent killing are the penicillins, cephalosporins, carbapenems, linezolid, and erythromycin. For penicillins and erythromycin, the maximum killing is seen when the time above the MIC is at least 50% of the dosing interval. For cephalosporins, it should be 60 to 70%, and carbapenems 40%. The antibiotics that exhibit time-dependent and persistence effects include vancomycin, azithromycin, tetracyclines, clindamycin, and the oxazolidinones. For vancomycin, a 24-hour AUC-MIC ratio of at least 400 is necessary. A brief note before we continue. You may see the AUC-MIC ratio described as follows. AUC 0 to 24 divided by the MIC BMD90 ratio is greater than or equal to 400 milligram times hours divided by liters. 0 to 24 refers to the AUC over a 24-hour period. BMD90 stands for broth microdilution and 90% inhibition of bacterial growth. Milligram times hours divided by liters are the units. As a shortcut throughout this lecture, we'll abbreviate the ratio and refer to it as AUC over MIC. Let's talk about the AUC-MIC ratio. For vancomycin, the AUC-MIC ratio has been established as the most appropriate pharmacodynamic predictor of activity and efficacy. Bactericidal activity is achieved when the vancomycin AUC over MIC ratio is greater than or equal to 400. This is based on in vitro and in vivo pharmacokinetic pharmacodynamic models applicable to human MRSA infection. But hold on, just wait a minute. One big problem is that there is weak evidence for the AUC-MIC ratio being the optimal predictor of efficacy. Experts propose this ratio based on in vitro animal model data and limited human studies. The data in support of this target is largely derived from neutropenic mouse thigh infection model data and limited retrospective clinical data to support this target. Another big problem is, how do you practically determine the AUC? There's been historical difficulty in accurately measuring the AUC in clinical practice. In the past, AUC monitoring required the collection of multiple concentrations over the same dosing interval from a patient. Then the clinician would calculate the AUC. This was too cumbersome to perform practically. So we're using troughs as a substitute for the AUC. Single vancomycin trough concentrations were easy to collect, so they were used as a surrogate or substitute marker instead of measuring the AUC. Experts stated that troughs could be used to infer the AUC. Such an approach is flawed since the correlation between the trough concentration and the AUC is not strong enough. In 2009, a group of experts created and published the Vancomycin Consensus Guidelines. These included 4 key recommendations. The first statement is that an AUC-MIC ratio greater than or equal to 400 is the primary PK/PD predictor of vancomycin's clinical effectiveness. The second statement is that trough serum vancomycin concentrations are the most accurate and practical method for monitoring vancomycin effectiveness. The third statement is that serum trough concentrations of 15 to 20 micrograms per mil can be used as a surrogate marker for the optimal vancomycin AUC-MIC ratio of greater than or equal to 400 if the MIC is less than or equal to 1 in patients with normal renal function. And finally, the fourth recommendation is that routine serum peak concentrations are no longer recommended to be used. With time, problems cropped up. Increased nephrotoxicity occurred when vancomycin troughs were targeted at 15 to 20 micrograms per mil, probably due to excessive AUC-MIC ratios exceeding 600. The MIC issue was brought up. Does a vancomycin MIC of 2 really exist, or is it just the result of lab variation? It was debated on how sensitive MIC measurements were. And finally, it was discovered that even with trough levels less than 15, the AUC-MIC goal of 400 could still be achieved the majority of time, in even greater than 60% of patients. Here is a diagram that compares vancomycin trough levels to their respective predicted AUC-MIC ratios. This chart was generated by a computer using what is known as Monte Carlo simulation. The author's findings showed that more patients achieved an AUC-MIC ratio of 400 to 600 with vancomycin trough levels of 10 to 15 compared to those with trough levels of 15 to 20. Also, a large percentage of patients in the vancomycin trough group of 15 to 20 had elevated AUC-MIC values in the range of 600 to 1200, which is associated with nephrotoxicity. This diagram illustrates the tremendous interpatient variability that exists when trying to estimate the correct vancomycin dose. So let's discuss where we're at right now. In the year 2020, the same group of experts published a revision of their 2009 Vancomycin Consensus Guidelines. The 2020 Consensus Guidelines were endorsed by the American Society of Health System Pharmacists, the Infectious Diseases Society of America, the Pediatric Infectious Diseases Society, and the Society of Infectious Diseases Pharmacists. Here are the 5 key recommendations of the 2020 Vancomycin Guidelines. Vancomycin trough-based monitoring is no longer recommended. The target vancomycin AUC-MIC ratio is 400 to 600. The nephrotoxicity rate increases with an AUC-MIC ratio greater than 700. Assume the vancomycin MIC is 1.0 micrograms per mil. And the preferred approach to monitor AUC involves the use of Bayesian software programs. So let's take a look at each recommendation a bit more closely. Studies have shown that there was a significant increased risk of acute kidney injury when targeting higher vancomycin trough concentrations, especially when the trough level is maintained above 15 to 20 milligrams per liter. Troughs of 15 to 20 milligrams per liter typically equate to a daily AUC-MIC ratio in excess of 400. By switching from trough-based vancomycin monitoring to an AUC-MIC-based method, using a target of 400 to 600 will maximize efficacy and minimize the likelihood of nephrotoxicity. An effective AUC-MIC target of 400 to 600 can be achieved with significantly lower trough concentrations than previously recommended. Most patients who developed acute kidney injury had AUC values between 600 to 800, compared with 400 to 600 in those without kidney injury. The prevalence of vancomycin-associated kidney injury varied from 5 to 43%. The mechanism is thought to be that the drug accumulates in the proximal renal tubular cells and causes oxidative stress. Most of the nephrotoxic events occur after 4 to 5 days of vancomycin therapy, and most cases resolve within a week of discontinuing the drug. Concurrent administration of nephrotoxic agents such as aminoglycosides, loop diuretics, amphotericin B, and vasopressors have been shown to increase the risk of nephrotoxicity. Recommendation number 4 states that we should assume the vancomycin MIC is 1 microgram per mil. Why? Because current susceptibility testing methods are unable, with a high reproducibility, to distinguish MICs of 1 from MICs of 0.5 or 2. Measurement of MIC values is an imprecise science, and variation of 10 to 20% is considered acceptable. The variability of reported MIC values seen in clinical practice is likely to reflect measurement error. There's a high degree of interlaboratory variability also between commercially available MIC testing methods relative to the broth microdilution MIC method and e-test method. The final recommendation states that the preferred approach to monitor AUC involves the use of Bayesian software programs. So what is Bayesian? Bayesian software programs predicts your patient's initial and revised drug dosages by matching your patient's characteristics to a series of previously studied patients and their pharmacokinetic parameters. Your patient's data is sequentially collected and added to this database of patient information and used as a model for subsequent dosing. Bayesian guided dosing is based in part on the Bayes theorem. It estimates an individual's PK parameter values based on the way the drug behaved in a population of prior patients, called Bayesian prior, and makes revisions using dosing and drug concentration data, Bayesian conditional posterior. The Bayesian software programs can estimate the vancomycin AUC value with very minimal PK sampling. 1 or 2 vancomycin levels are required. So how does Bayesian work? It uses 4 components to make predictions: the basic pharmacokinetic parameters of a drug, a repository or density file that contains models of kinetic data from past patients, your patient's doses and collected PK data, and your patient's target goals and estimates of future dosing regimens. Why might Bayesian be better than other methods? Well, vancomycin concentrations can be obtained and analyzed at any time. Bayesian dosing is shown in the guidelines to require only drawing half the levels of other approaches. And with the Bayesian approach, vancomycin concentrations can be collected within the first 24 to 48 hours, rather than waiting until steady-state conditions. So what are some limitations of using Bayesian kinetics? It is expensive. There's added cost of the software. Evidence is lacking. There's a lack of prospective data. No high-quality Level 1 recommendations are seen in the guidelines. The cohort of patients. Do the characteristics of patients in the data repository match the demographics of my population? Loading dose. If a loading dose is given, what is the need to get levels so early to adjust the dose? Diverse patients. Can the software be applied to obese, critically ill, pediatrics, hemodialysis, or changing renal function types of patients? And complicated. It requires access to computer software and knowledge of Bayesian modeling. The user may just depend on the software. So in what direction do we go from here? So here are our choices. The Bayesian approach is recommended, but it is associated with several key disadvantages. Trough-only based monitoring is discouraged by the current consensus guidelines. The third choice is to use what is known as the linear trapezoidal method, which is a new way to dose and evaluate vancomycin using AUCs. Well, we have run out of time, so we'll talk more about the linear trapezoidal method in Part 5, our final installment of Practical Pharmacokinetics. Let's summarize what we learned in Part 4. We reviewed the history of vancomycin. We compared pharmacokinetics and pharmacodynamics. We identified which antibiotics uses concentration-dependent, time-dependent, or time-dependent persistence effects killing mechanisms. We outlined the 2009 and 2020 Vancomycin Consensus Guidelines and listed their positives and negatives. And we defined how Bayesian kinetic modeling works and stated the pros and cons of using this type of predictive software. In Part 5 of this series on practical pharmacokinetics, we'll learn how to use the linear trapezoidal method to dose vancomycin to AUC targets. We will also review dosing in special populations and daily monitoring techniques, so stay tuned. Thanks for tuning in to watch this installment of the PharmEasy Tutor. I hope you learned something that you could use at school or in practice. If you'd like to continue to see more of these types of tutorials on YouTube, please make sure to click on the subscribe button below to change it from red to gray. Also, if you like this video, I would appreciate it if you can click on the thumbs up icon below to change the color to blue. If you have any comments or questions, please feel free to add them in the comments section below, or share this site with someone else. Stay tuned to the PharmEasy Tutor channel for more lectures in the upcoming weeks. So until next time, remember to take it easy.